in the panel, in the round table, the investigators and the drug developers, the physicians discussed how to best manage all of the disparate symptoms that are exhibited by COVID and how you get those patients together. And there was a distinct line between the lumpers and the splitters, people that were pro putting all your patients together and people that were pro splitting that up. So in a better way, can each of you describe the lumpers and the splitters?
Well, because of the vast symptoms and organ involvement in long COVID, I think the lumpers are are those that were identifying themselves as seeing the issue as a lump of these are a group of COVID's long-term sequelae subjects who have multiple symptoms associated with COVID. And then the segmenters are saying, well, I think it's important to solely look at each symptom and each body system separately, even though we realize that there is a lot of symptoms that can be involved, and the impact of COVID is affecting multiple symptoms, and subjects routinely have a lot of symptoms involved in their long COVID challenges. So again, it was a way of looking at doing the research and getting to find and define endpoints. Do you want to look at as a lumper with you're looking at subjects and then stratifying within that big subject pool, or if you're going to enroll subjects only with fatigue, or but then in that case, if you're looking at that segmented component, you're also looking at really minimizing your patient population simply because there's so many with multiple symptoms.
To me, the most important problem is definition. It's not clear to me whether we should be lumpers or splitters. There's a variety of symptoms, and as mentioned, a variety of mechanisms. Some are not unexpected, like the progression of a bad pneumonia to leave residual pulmonary symptoms. But there is a funny constellation of symptoms which we feel go together with mechanism. And if we do it as one lump sum, we may miss the boat because various disease presentations may respond differently. One of the things that would help would be if there were objective tests for some of these syndromes or constellation of symptoms. For example, the antibody test that was mentioned. People have done muscle biopsies in some of the patients who complain of muscle pain as a major concern, and virus is rarely seen. Inflammatory and immune cells are prominent. So maybe in some cases, a muscle biopsy. The neurologists concentrate on POTS, postural orthostatic tachycardia syndrome, and a number of these patients have symptoms, and when they're put on a tilt table, react as POTS. So I guess I'm trying to avoid putting the person who has a lung that's fibrosed because of a bad pneumonia in someone who's having brain fog, fatigue, and some non or ill-defined symptoms. And how to do that is, I think, for now, based on what few objective tests we have and what we can distill from observational studies. But I think we should be doing studies that kind of separate groups so we can find out if one group responds, maybe the other group doesn't. And if all the groups respond equally, then maybe we will end up with a unitary theory of this syndrome rather than dividing. But I'm more of a cautious splitter, not down to symptoms, because that'll give you 80 groups, but to constellation of symptoms.
And to come back to this discussion on splitters versus lumpers, I think, and I agree with Michelle, that we need to learn first, but at the same time, we will need to split some subgroups, because it's very clear when you have a cardiologic problem, or if you have a lung problem, and you have more lung problems, obviously, because many people had respiratory dyspnea and so on. So for these people, especially those who had mechanical ventilation and all the type of possible lung fibrosis as a consequence, that for this type of patients, you're not going to wait for more information to start to treat them with some drugs which can tackle the fibrosis issue. And that's why in this list that I showed, you have already 5 or 6 drugs, or 5 or 6 clinical trials, but mostly with the same drugs, actually targeting the fibrosis, which may be a sequelae of the lung inflammation.
When I think about the patients that I see, I separate them into 3 groups. So I'm a splitter. One is a group of patients who were critically ill, have evidence of end organ damage, and yet their symptoms are improving. Okay, and that may be a survival bias in the patient. So these are patients who had ARDS, who have evidence of ARDS fibrosis, for example, and yet are feeling better than they've ever felt before. The second group are those that were not perhaps that critically ill, are coming in with specific complaints and have evidence on testing of specific end organ damage, whether that be on cognitive testing, whether that be on pulmonary function testing, cardiac testing. And those are, that's a big group, and it's an easier group because you have a symptom and a complaint, and you have an organ system that's being affected that you can actually do a measurement on. The most frustrating group are those that had COVID, severe or not severe, have persistent complaints, and yet none of our conventional testing under anything we do is showing abnormality. And that's the most interesting group, I think, because we're obviously not testing the right thing. And so I think that, what we need to think about is think a little bit outside of the box, in the sense that we really don't know what's triggering these symptoms. Perhaps there is a mental status exam that we should be thinking about incorporating. Perhaps there are other tools, like looking at muscle fatigue in a way that we don't normally look at it in clinical practice. But I think that group is really the one that's creating the most interest, as far as I'm concerned, but also the most frustration, because they're persistently symptomatic, and yet we don't have a good way of measuring what the problem is.
So I guess the manifestations, the clinical symptoms, which will be the most difficult between splitters and lumpers, will be everything related to neurology, depression, brain fog, and all these things, because these can belong to tissue damage and to unresolved inflammation. So you find them both on both sides. But for other manifestations, it will be more lung damage or ongoing inflammation. And we will need biomarkers also to split these patients. We mentioned the autoantibodies, and probably in order to screen the patients in one or the other types of lumps, we would need to check the presence of autoantibodies.